so that we can get started. So we're a little bit late, but I'm really grateful that we're here. I suspect, well, hopefully other people will join as we, as we go through. So, and I'm recording this because, we're going to try to post this in the community, hopefully, and also on YouTube, so that people can catch it later if they weren't able to come now. So, welcome to everyone that's here. The topic this evening, this is our very first Calm Care Spotlight, which is about A&E preparedness. And while this is dementia-driven community, we're doing this for all caregivers because it's a real issue across the board when we go to A&E and we're not prepared. When you're caring for any kind of patient, an older adult, a stroke survivor, a child, someone who has asthma, you name it, dementia, tonight, hopefully we can talk about what to bring to any, what to say, and how to stay calm when we're in any, because it is a really difficult situation. So tonight, of course, we're joined by my very good friend, and also just a fantastic GP, a fantastic doctor, and she works out of Medical Associates Accidents and Emergency. And her name is Tanya Edwards, Dr. Tanya Edwards.
You're muted.
Not
Deborah,
hearing me?
no, you're mute. You're muted.
Oh, okay. Where did we leave when I was saying my good friend Tanya Edwards?
Yes. Pretty much.
Right, who is an accident and emergency physician. She works at Medical Associates. Tanya also lectures in the gerontology programs at the University of the West Indies, and she holds a further degree in gerontology. I always mention that for Tanya because she studied in Malta, which is the gold standard for elderly care. Is widely recognized as a gold standard for elderly care. So to have studied in Malta and to have studied about the elderly in Malta it's quite the thing. We're very, very lucky to have Tanya in Jamaica with us, right? So hopefully, we leave with the idea of what a go bag is, how to do what we call a 60-second handover, some advocacy phrases that we can use, and some discharge questions that it would be a good idea if we ask the doctors. And we're going to also talk about, we'll include a section about memory loss and dementia because, it can be very stressful, I'm sure, for can be uniquely stressful for dementia, but the basic tools we're going to talk about, I think would work for most caregivers, if not everyone. Okay. So Tanya, is there anything else you want to add to your introduction? And shall we get started? Go ahead.
Well, thank you, Deborah. So the only thing I probably would add is that, I'm passionate about elder care and fitness. Yes. One of the things Deborah didn't mention is that I'm also a physical therapist. So yeah.
This is how we met.
Yes. So yeah. So I use my physical therapy background and other as well. Also have a master's in public health, gerontology. So that also helps in terms of advocates for older adults. Yes.
Yes. So let's get started. Let's talk a little bit about what A&E looks like, what it's really like, and what kind of happens in A&E, right? So let's talk about, what happens when we first arrive at it. Can you give us an idea?
Okay, so
go ahead.
Yes. So accident and emergency, I mean, anywhere you go in the world, it's a very intense, busy place. It can be a little intimidating at times. I work at a private hospital, but I've worked at university hospital, other settings in terms of emergency care, and it can be very busy. And as I said, very intimidating. And so when persons come to the emergency room, they want to, because everybody sees that their condition and their relatives as being urgent, is an emergency case, and they want to be seen now. But it doesn't work like that in the emergency room. There is a system called the Triage system. We use the ASI, which is Emergency System Index. And so persons are triaged. Sometimes they may not be triaged formally. Like I can look at a patient and say, no, this one needs to go. We need to see this person immediately. So they tend to be seen by a triage nurse. Some hospitals may have a doctor doing the triaging or at the assessment. And so the levels of this ASI is from 1 to 5. 1 is the most urgent and 5 is the least urgent. And so based on that, you're seen. So for example, somebody may come in with a headache, and another person, while we're assessing that person for the headache, someone may come in with an allergic reaction. Of course, the headache is very important, but the allergic reaction is most urgent. And so we will
Yes.
kind of
Yes. And I think
leave.
that's something that people don't understand. All of us wonder sometimes, including me, like why does
Yes,
it take so long when you go to any? And we do tend to have that sort of first come, first serve mentality where it's like, well, I was here first. But it's different from the perspective of the doctors in it. They have to prioritize, in terms of what is
right.
most life threatening, and they're not prioritizing their emotions. They're prioritizing based on systems that have been developed for how is it that we make sure that we deliver the care to the people who need it most urgently. So I'm very very glad that you mentioned that, because I think people do tend to have that sort of thing, like, okay, if I was here before her kind of thing.
Right.
Talk to me a bit about, for everyone who does have to go to any, what do we need to know about, what helps us to speed up care? Like what is it that we need to say and do and understand, to if we have, so the emphasis is if we have a case that is very urgent. Because people, if you're in any and someone just got shot and you're also in any, the person who got shot,
Yes,
so I'm
there's a
not saying
delay.
that we must I'm not saying that we must misrepresent ourselves to try and get attention from the A&E doctors. But what are some of the things that you want to hear from us when we come into A&E that let you know if it is urgent? Because I think it's very important for caregivers to understand that you are the advocate for the person that you're with. Oftentimes they're very ill. When you go with them, you have to be able to speak up, not to be boisterous and make everybody's life more difficult by being aggressive and so, or being perceived as aggressive. But you
Mhm.
do need to let the doctors know, and the nurse who is triaging, what would be like the words that would make you sort of say, okay, this is someone that I probably need to see very quickly.
Okay, very good question, Deborah. So, to prepare for any, the preparation starts from home or starts from where the patient is. So the caregiver has to start from home to prepare for any. So you don't come there in shock, because sometimes there's panic on both sides. So the caregiver is very apprehensive, very nervous, and then the patient is also very nervous about what's happening. So the first thing is to start preparing from home to bring this patient in. Um, and so that will help speed up the whole process. You want to
Yeah,
know, once you come
because
in,
you're organized.
yes, so you're organized, you're calm down, everything is taken to the emergency department. Um,
So that the doctor has all the information that they need
right.
to
So
make
for
the decisions.
exactly. So if you have all the medications, make sure you have a medication. Deborah had mentioned a go bag. All the
Yes.
medications. Some so have a bag with everything in all the medications in that bag so you can just grab it. The other thing is good to just make notes. Have a little folder to say these are the vital. This is what I had taken. These are, when I say vital, the vital signs, so the blood pressure, the temperature, the respiratory rate, the pulse rates. You have all of that. Because we're going to ask you these questions and we're going to ask them very quickly, you know?
Yes.
And so when you get into the emergency room, you would have already had these information. The other
Yeah.
thing, when you get into the emergency room, we don't like hearing long stories. So don't say, we say, why is this patient here? Or, from last week, we want to know what's happening now. Once we've
Right
gotten
now.
all the information about what is happening now, then when everybody's calmed down and we have settled the patient, we're like, okay, so tell me what happened last week, and who is what happened last week? Who is the follow-up physician? Is
Yeah.
there anything else you want to tell me that you didn't get to
Yes.
tell me? And then
Yeah.
yes.
In the instance when it was really an emergency. And let me say, I have, I've actually have a set of scripts. I'll stick them in the community for you, because
Mm,
there's really a formula for that. So that the patient, so that you can within 1 minute, I call it a 60-second handover. You should be able in 60 seconds to really say to the doctor, the things that they really need to hear. Who is this person? How old are they? What's going on with them in terms of condition? Why are they here, as Tanya said?
mm,
What's the main symptom they're having? When did it start? How severe is it? And what has changed? So, if you
right.
come and you say, well, this person has dementia, yeah, that's lovely to know. But what has changed? Why are they here in front of us right now? Right? What's going on with them in terms of, do they have, do we need to know about medications? Blood thinners particularly are a big thing. Do we need to know about insulin? Do we need to know if do they have seizures? Are they dementia? Are they all, these things, risks, are they on, and, as I said, blood thinners, kidney disease, do they have some issues? And what is your main worry? Which is, to say, okay, so I'm concerned about this. This is the thing that I'm really concerned about. Okay.
Right.
Let me see if I can, because I think it's really good to have the scripts, because then you can hand over to a person, you can hand over to the person in any really quickly, so that
Right.
they can also have an understanding of why, what you're actually here for, in a way that, since it is an emergency, most people are not going to any, to, for any sort of for any sort of entertainment. They're going there
No,
because
you're right.
there's a problem, right? So hang on a second. Let me see if I can bring up this script, and put it on the screen. And as I said, this will be available. I'll stick it in the Skool community as well, so that you have it as a resource after today's um, after today's conversation. Let me see if
And
I can
another
share.
thing, Deborah, I want to mention is one important factor in terms of speeding up the time, or speeding up the care time in A&E, is the caregiver themselves. Sometimes the caregiver will come with the patient, but they may be new, or they're not familiar with the patient, so they have to, I have to call so and so, or I have to call so and so, or they can't give the information, so they have to call a relative, and that sometimes I will put, there's a
Yeah, it
delay
takes
when
a
that
lot of
happens.
time.
Yeah, it takes
It
a
takes a
lot of
lot of
time.
time.
Right. So if there's
It's
anything that happens, like anything acute, my advice is let that person come. They will say, oh, I
mhm.
wasn't there, it was the other caregiver, and
Yeah.
so you have to be calling to say what happened, and so there is the delay as well.
So I hope you guys can see my screen,
Yes.
which is talking about what I'm talking about, which is, having a structure so that you can answer. You know what you need to tell them, who, what conditions they have, why are we doing this now, Are there any red flags? What has changed baseline versus today? Any allergies, any risks, and what your main concern is about the patient, right?
Right.
And just giving an example, as I said, we'll stick this in the community so that you guys can see it, and you can go through and see. But this is an example script. So Tanya, you can critique this for me, right, and see if this makes sense. So this is a 60-second. Hi, doctor. This is my father. He's 72. He's got high blood pressure and diabetes. We came because he developed chest tightness and shortness of breath that started about 45 minutes ago while he was sitting at home. The pain is central. He says about 7 out of 10. He's sweaty and he feels weak. He has no history of a fall or injury. His usual baseline is that he's fully alert, talks normally, and walks independently. Right now, he's breathing fast and he can't speak in long sentences. He takes all of these drugs: amlodipine 5 milligrams, metformin 500 milligrams twice daily. Not allergic to any medications that we know of, not on blood thinners. And I'm most concerned that this could be a heart problem that's getting worse.
Great.
Yeah?
Yes.
So,
Yes.
and I'll this in so that they can see the structure, and then they can also see, how, the wording of it. Here's another one really quickly, guys. This is someone with a stroke. Hi, my aunt, she's 68 with hypertension. We came because she suddenly developed the signs that we should all know for stroke. Slurred speech, weakness on her right side. Started at 4:10, so about an hour ago. She already has facial droop, no seizures, no falls. Normally, so we're telling them what the baseline is. She's fully independent. She speaks clearly. She walks without help. Today, what has changed? She's struggling to lift her right arm, and her speech is not normal for her. She takes all of the medications, losartan, 50 milligrams daily. She's not allergic. We always want to know that. She's not on blood thinners. We always want to know that. My main worry is that this is a stroke and we need urgent treatment. And as I said, you'll find this in the community, all of the different episodes, so that you can kind of take your time away from here, away from this very limited time. You can look at the scripts and you can look at the principles, and you can think about how you compile that so that when you go to the end, you're not like, right?
Right.
And the go bag is super important as well, because the go bag should have this data in it, right?
Right. Yes.
So that when you're coming to A&E, you've got all of this stuff on board. Let me see if I can pull up the go bag stuff as well. Please bear me, guys. And all of this stuff will be, again, as I said, I'll put it in the community. You don't have to worry about oh God, I have to write all of this down.
I'll remember
You can
them.
just print it. Yeah, you can just
Yes.
print it down
Yes.
you can just print it down from the library, right? So everybody hopefully knows how to get to the library. And if not, watch the video at the top of the community that explains how to use the community easily, right? Because not all of us have the time to sit and figure everything out. So hopefully this handout will be better organized in the community. But this is just basically the contents of what an A&E go bag should be about, right? It's about 4 pillars. Tanya, again, jump in, because
Yeah.
you're the one who you're the one who
Right.
they're coming to with this stuff, right?
Yes. Medication is
So
very important. A lot
yes,
of times, person, I was rushing. I didn't bring the medications, and
yes,
often, yes, we will give them medications in the emergency room based on the assessment, based on the diagnosis. But sometimes we may not do what we call treatment, so they may not get any medications. The only thing we may do is just do blood tests, and so we're waiting on the labs. Oftentimes, though, you may have these persons, they come into the A&E, but they're on medications. And so, being in the emergency
yes.
room, that may take some time. And so they may be taking blood pressure medication twice a day or other medications in the evenings. And so they will miss that dose. So
And
oftentimes
also the
when they're,
risk of interactions. You guys really need to know so that you don't
and we
give them
need to
something
know,
that
we need,
is,
what we do is that we vet the medication. We just don't list them. I look for duplication
yes.
because some persons quite often, especially for the older adults, they will be taking the same medication, different brands, but the
Yes,
same
polypharmacy at
medication.
its
So you
worst.
have
Yes,
polypharmacy including duplication of
yes,
medications. So
yes,
they may
yes,
be on a pain medication, for example, they're on cataflam, but they're on diclofenac something, and the
yes, which is
cataflam
the
and the
same
diclofenac
thing.
is the same thing. You know, they may be on clopidogrel, which you may on clopidogrel, the name called clopidogrel, and they're also on Plavix or something, which is the same. So they're
Just,
taking the
a
same
blood thinner.
medications and
Yeah.
blood thinners, yes.
I would say in your go bag, it probably sounds like it would be good to have a copy of the prescription,
Oh, yes,
in
yes.
addition
Yeah.
to, having the meds, gathered up as well. And having, I'll create a log for you guys so that you can write in everything in one thing and maybe
Mm,
stick it into a folder.
right,
They do need to know if people are allergic to things, especially medications. One of my sisters has a super allergy to some stuff. And that is it's really important that people know that, because sometimes in an emergency situation they're allergic to the exact thing the doctor might want to give.
right.
you know
Yes.
so it's and in a situation where you've had to bring someone to the end, you like me, your brain might not be firing on all cylinders. So it's really good to, yeah, because the shock, the rushing and everything else. So
And the
it
panic,
might
yes.
exactly. So it might be good to, it is good, to have in your go bag. That's the very first component of a go bag, which is just having the
Medication.
information about the medications. And if you can, and just have the list of them, have the prescription, even if it's a photocopy, so that you don't have to keep digging up in the go bag when you have to fill the prescription. At least have a photocopy of what they're taking, and make a list of their allergies and so on, so that you don't, and what their diagnoses are, so that you don't have to be trying to remember that in a hurry. The second thing is the second thing should be in any go bag, I'm suggesting, is documents, money, and the logistical thing. So some kind of ID, in case at some point, the person either has to be left alone, or the person is, you need to do something with registration, and so that requires that. Your insurance cards are, I think, almost at every hospital. If you're coming from someone, the letter about that. Any other letters that you might have that are recent. So don't give Tanya the 2 years ago MRI. She doesn't, really need that. But if they, I would say within, what would you say, Tanya, the last 6 months or the last three?
The last 6 months, I mean, the truth is when they have any result, any result from labs or imaging, I look at them, whether it's year ago, and if
Yeah.
I need to do it again, what I will tell them to go back to the same place so we can make the comparison. So, for
Mm-hmm.
example, if they've done it at, for example, Apex, they did an MRI 2 years ago, I would still read it, and based on their presenting complaints, if they do need another MRI, I would say go back to that MRI place so that we can make the comparison.
The
I still look at
comparison,
it,
that's
right?
excellent.
Yeah, I still look at it.
Yeah, man. I didn't know that. Things like a vaccination record, if it's, I mean, if you have kids, that goes without saying. And, obviously with the COVID vaccine and whatever other
Mhm.
things, like I do meningitis, for instance, because I'm in health. So, and all my cards for that kind of stuff are in one Ziploc container in my go bag, right? And
Right.
then, cash coins, your card. I always say, please bring snacks, because, it is heavy and sometimes it's long. Just be careful that you clear it with the surgeons, with the doctors, so that,
Yes.
because some patients cannot eat. So,
Right.
be
So
careful
when
about that.
yes,
Mhm.
when I saw that part, bring snacks, but ensure that you speak to the nurse or the doctor, because while we're waiting on results, we prefer for the patient to not take anything by mouth, not eating until we get the results. Because sometimes, based on the result, you have to do an intervention, and if they have eaten, then it may be a
That will delay it.
contraindication and delay it. Yes.
Hygiene as well, a change of clothes, because you might be there for a while. And that's not just,
Mhm.
I mean, for context, it's not just any in Jamaica, waiting times in, for example, Toronto General and so are equally long, right? So making sure that, and and a bag for soiled items, so bring a change of clothes with you, bring some wipes, bring some sanitizer, tissue.
A blanket.
Yeah, it is cold
A&E
in
can be
any
cold.
usually.
It's usually very cold in A&E.
Yeah, so a blanket is excellent. A
I'd also
towel,
bring a bag in the yes, a
bring
towel.
up, bring
I
up.
was bring a what I was going to say, a bag in the event that based on the results that the patient may need to be transferred to a different
Yes.
hospital or they need to be admitted.
Yeah, change of clothes at
Mm.
least, so that you can, and when we say change of clothes, I mean include like a nightie, as she said, so that if they need to be admitted, they have some stuff there. I am
Right.
a big fan always of bringing like toothbrush and stuff with me everywhere. So you can consider that as well.
Right. They're
Your
basic toiletries.
Yes, so that you have something, you have the wipes, yes, but you have something. If you're thinking you might, even if you don't think it might be an admission, it doesn't hurt to put a bar of soap, a toothbrush in a container, and a little bit of toothpaste and stuff, so that if they are an admission, at least you're set up for that night, and
Right.
then you can regroup and get the additional nighties and stuff instead of having to rush home and rush back and all of this stuff that gets really difficult. And then,
Also,
of course, things that I, as a person who deals with dementia, I'm going to beg you all to please bring the people's glasses
and
and
hearing
their
aids.
hearing aids,
Yes.
because that is extremely stressful for the doctor and for the person, right? So you can either do duplicates if you can afford to, you can stash duplicates in the go bag. If not, I recommend that you put a checklist on the fridge. So, and before you go to any, you run down the checklist to make sure that you have everything. Because as I said, at that point, you're not going to necessarily be able to pull, I certainly wouldn't be able to pull everything out of my head, right? If they need their walkers and their canes, a mask, if they need a notebook, or you need a notebook, right? And your chargers and so on, so that
Right.
everybody,
Bring your chargers and make sure that credit is on your phone if you're not postpaid.
please.
Yes. The other thing that
That's
they
a good
can
point.
bring in some patient, not just dementia patient, but sometimes they may have a comfort item, something that they like,
Yes.
their favorite thing. Some may like have the tablets. They may want to be on their phone, and they may have a favorite blanket. Bring these things for them because it helps us settle them while they're in the emergency
Yes,
room.
waiting, and even if
Yeah.
they're, in examination and so on.
Right.
So, we've spoken about, all of that. And then you also need to consider, caregivers, the people that you're taking care of, what their triggers are, what helps them to calm down. That's really good information to have, so that you can share it. Like if there are things that, like bright light in their eye, or whatever it is that is really gonna trigger them. I've been in any with dementias with a face, the eye masks, because some of them get really irritated with the overhead, the very bright daylight overhead light. And like Tanya said, a comfort item, which is here,
Yeah.
right? So again, this stuff will be in the community, so that you guys can look at it and begin to build your go bag if you don't have a go bag already. And just the act of building your go bag is gonna help you to be more relaxed when you have to go to any, because you have it already. You have most of the things in place. You have the list on the fridge, so you can pull it down and say, okay, let me just make sure I have everything. Glasses, this, that, right? And then when you go to any, it's not this experience of, oh my gosh, and on top of this being stressful, I forgot this and I don't have that, and let me call someone, as Tanya says, right? The ruler, I put the rule here, but I would say go through the checklist. If you have the allergy list, the baseline and the main symptoms, and the ID, right? Also, if someone other than you is the person that needs to be contacted for like let's say the person is, has to have surgery, and someone else has power attorney or whatever, it would be good if you had that information in a way that you can pass on to the doctors so that they can take it from you and go call the person if they need to. Tanya, you can correct me,
Yes, I
but
agree
I
with
think
you.
it's yeah,
As what I mentioned earlier, that the preparation for A&E starts from home. So you can also call the relatives. One of the delays we see in the emergency room is like when the caregiver comes, they have to call somebody from abroad to for them to get permission to do so and so and so. And sometimes there's a delay because I can't get that person. We're
yeah,
waiting for them to return the call, and they have to discuss with the siblings. And you can think about what happens when you have that delay. So sometimes you
yeah.
want things to be done right now.
Yes,
So it's
because you
good
are
to.
in an emergency situation. You are in
Mm,
an emergency
yeah,
situation. So if it is, it would be great to, if we know we're going to any, maybe you start to try and get these people before you leave home
exactly.
so
I
that you
agree.
are, and so like if there's a gap of time before they call you back, at least you've made all of those calls before you departed, and if you get them, then have those discussions before you go through
Mhm.
the door so that they know that the next call they get might be from a doctor saying, hi, this is the situation and your permission, or we need whatever we need from you. So that is good. I really agree that it makes sense to build the groundwork at home
Mhm.
so that you when you get to any, it's not, because all of these things, the reason I talk a lot about planning in this community, and I talk a lot about planning both for dementia and just for caregiving generally, is because when we don't plan, we burn ourselves out really quickly, and caregiver burnout is
Mhm.
a real problem. And then on top of it, the last statistic I heard is 40% of caregivers die before the person they're taking care of.
Exactly.
So really respecting that these little ways that you can take care of yourself as well as the person, without having a constant escalation of stress, and one of the ways you can do that is through organization. It's just being, just planning ahead. Some people will say, oh, I don't want to think about the worst. Yeah, okay, I get that. But if the worst does happen, it's gonna be 4 times more stressful if you're also not, if you haven't thought of that before now.
Mhm.
And stressful for everybody, stressful for the doctor, stressful for the person, the person you're taking care of, and stressful for you. So moving on a little bit from that, and as I said,
Deborah, I want to mention one thing.
yeah, of
There's
course.
something called, we see it with children, and there's no way I'm comparing older adults to children. They're not, but there's something called anxiety separation,
Mhm.
or and sometimes when in the emergency department, well, from where I work, we we actually promote the caregiver to stay with the older adult
Yeah.
because there's some separation anxiety. You
Mhm.
know, sometimes they're the ones that will cause us to be able to, do the procedure in a
Yeah.
comfortable way because they're there and they can reassure and
Reassured and
and
they
they're
feel safe.
and they feel safe and there's a familiarity. So there's familiar face and they can say, Miss So and so, Mr. So and so, I'm right here. You're going to be fine. And because they
Mhm.
trust that person, they believe that person. And so we encourage the caregivers to stay with the older adults. Sometimes, I'm not going to say quite often, sometimes once the older adult comes into the A&E, the caregiver can't find the person. you know they're gone
Wow.
somewhere,
Wow.
do other things, and so can't find them and they become restless, the older adults,
Yes. Yes. Yes.
especially with the
Yes.
dementia patients. They become
Yes.
restless, so
Yes.
we
No,
promote for them to
dementia.
stay. I would say just sit by the
Mm,
bed, yeah, so they know that you're here, talk to them.
yeah, I
Yeah, so
agree.
that's also very important. Hmm.
Thank you for that. Can we talk about so before I go into, how you can advocate without you and the doctors getting into a fight, basically. Let's talk a little bit more about what you were saying, which is, just reducing that stress when you're, and preventing those complications you can have when you're waiting, right? So we spoke about, so the caregivers give us staying, as you said, so that we don't get that
Hmm.
separation anxiety response. keeping the person hydrated if it is allowed. And again, we are going to remind you that you do need to ask the nurses and so on if that is possible in your individual case. Things like pain, things like needing to go to the bathroom, things like trying to limit. As I said, I've been in any with headphones and face masks, trying sometimes to just decrease the overstimulation. And it can be a busy place, it can be a really noisy place as well. And trying to sort of manage that a bit for the person, is really important in terms of, I think, in terms of, and also talking to the, Tanya mentioned it earlier, and I think this is a really big thing, which is talking to the staff to make sure that they can take their meds. If they're due meds and they're in any, it's good to take your meds and to ask the staff, say, look, she's due for this now, or he's due for this now. Can I, is it okay for me to give it, and so on. So that it's any kind of disruption, especially the kind that's gonna have a knock-on effect for the doctors,
Right.
like the person passing out or something, having a hypoglycemic moment or whatever. So see if in those little ways as well, where we try to manage. And it's uncomfortable for everyone. I've been in, it just is. But we want to try and make it as comfortable as we can, and just make sure that there, as that everything that we can do to reduce the difficulty of it, that we can do it. I want to talk a little bit about talking to the doctors. So I say it a lot that the caregivers are the advocates for. Oops, where did Tanya go? Tanya's, bear with me a minute, ladies and gentlemen. Tanya looks as if her internet has, she looks as if her internet has done something. So let's wait a little bit. The next thing that I wanted to talk about with her was about the fact that we are the advocates for, Hannah, I see your back. So, caregivers, we are the advocates for the person that we are with, whether or not we like it, whether or not we chose this, etc., etc. Especially if someone is very ill or there are dementia, which is my particular wicket. We are going to have to speak for them in a lot of ways, and we also have to get some information from the doctor. We have to give information to doctors. We also have to get information from the doctors. And it would be nice if we could do that without it becoming conflictual, because we do sometimes, you are already very activated by the fact that you're in an emergency situation. The doctor is activated because they're trying to get this straight to what is happening and actually help. Tanya is extremely calm. I've seen Tanya at work. I don't know how she does it. She's extremely calm 99% of the time. Everybody's human. But I've been in any where as I said, that you are activated as a caregiver. The doctors are activated because this is an emergency and they really are trying to move as quickly as they can. And you need information, right? One of the things I would say is, because I get it a lot on the other side, and it is very exhausting to be like, so what did the doctor say? And it's like, oh, I don't really know. I was so there, and you're like, this is not helpful. And for me to find the doctor back to say, okay, so what exactly happened there, especially in an emergency situation, the doctor can tell you, the doctor has long moved on. Like there, can be 15 emergencies in one night. And they might not even be on duty the next day, etc., etc.
Right.
Ideally, they've written stuff up for you so that you can, so let's say I had a patient who went to medical associates in me having had a fall. And she actually had old compression fractures that looks like she had aggravated them. And he wrote a note for the physiotherapist because they had their concerns, and medical associates, and he wrote a note that she could pass on to me. Having said that, sometimes that might not happen, right? And also, if the person even is an admission, you want to ask the doctor what is that about? What is the plan? Can I have an idea of what it is that you're most concerned about? Give the doctor a chance to actually have a thought, like don't ask them that the minute that they've arrived, just try and figure out what's wrong. But you should leave any with an idea of what the doctor's concerns were, right? If there's while you're in any, say if the doctor is leaving you and saying, okay, so nurse is going to come to do this and that, you should be asking, is there stuff that I should be looking for while we're here? Because a stroke, for example, it can progress, it can develop. If it's a hemorrhagic stroke, they can go from, so the doctor, there are things that the doctor might want you to come let them know if that is happening, while they are, elsewhere in any or doing some other thing, right? And asking them for, if you need to write things down, if they need to repeat things for you, and if you're not admitted, so if you are admitted, what's the plan, right? What is it that what is it you're concerned about? What are we planning to do next in this situation, etc. If they're going home, probably what are the next steps for us? Do we need, most doctors will, just provide you with, if you need prescriptions, if you need whatever. But it's good to ask the question, because we have to remember also they are busy. And as I said, we are the advocate for them. So before you leave, it's good to ask if you're leaving, what are our next steps? Are there, is there any prescription? Is there anything else that we need to do going forward? Do you want to review yourself? Or should they go back to their regular fill in the blanks? Ask the questions. You are the advocate. It does not serve any of us for you to leave any having no idea and having just had this whole adrenaline rush and emergency. It does, and as I said, it's hard on the doctors too, because for us to go back and say what exactly happened there, they're like, oh my gosh, let me find that file from 3 nights ago when 5 people came in who had cardiac arrest, So
Yes.
try to get that information and try to ask them what, it can, I've put have some phrases here, which is, like, can you help me to understand what the plan is for today? What are you most concerned about as a doctor? If you really care, what are you ruling out? I don't care. When doctors are working, I'm like, tell me the end results. Tell me, because when you're differentiating, I just want you to, if you suspect something, do what you need to do to confirm that or rule it out, and then tell me what you think it is. But some patients will want to know what is the thinking. Are you thinking they've had a heart attack? Are you thinking that this is an exacerbation of something? Are you thinking they've had another stroke, right? So ask the questions, and remember that it is, you're dealing with someone also who is trying to work quickly. So, be calm, keep your sentences simple, and, just ask them what it is that what you need to know, so that, you come away from any, even if you don't have anyone outside of any to advise, what happened in any, what, has there been a change, new medications, new this and that, who do we see next? Do we need to see somebody next? Or can we just go home and forget about that experience? All of that we need to consider. That's what I would offer you. And as I said, please, I'm just asking, I'm not accusing anybody, but please speak to our doctors respectfully. It is hard enough to be in any, oftentimes at night when everybody seems to get sick. And then, you are activated. We understand that it's stressful for you, but please try to, not have to go back to any the next day to apologize.
Yes. And we do try to explain what's happening. And sometimes it depends on how busy it is. I mean, I'm at work now, so and it can be very busy. But the nurses, I can speak for medical associates, but for most doctors, they want you to ask these questions, but they don't want to be asking. Sometimes they ask them very often, so they want information right around the clock, every minute. But sometimes we're waiting to get all the results to come up with a conclusion, and to see what's the best next step. But personally, I would explain. I like to explain to my patients,
You're good at that. I've
and
seen Tanya at work.
see what, and the nurses, they will come, they will help as well in terms of explanation. A lot of the times though, you say to the caregivers, do you understand what I'm saying? Yes, 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 yes. Okay, repeat. Tell me what I just told you. Me understand, man. Me understand.
And you know that that just went.
And then I would hear them at the nurse's station and say, "Boy, me not hear, me not understand nothing what the doctor just said."
Yes.
And I would call and say, "I just told her everything," you know.
Yes. No,
But
and Annie
don't
is
don't.
whereas I can give you handouts, Annie can't do that.
Yeah.
You don't have the
So if
time
you, we're
to
not
do
going to
that.
say why you can't understand, you know, that is how we were trained to.
Hmm.
Once we tell you, we said, "Do you understand? Tell me back what I just said." You
To
know,
check understanding, yes.
like understand. The other thing is that when we have to write a prescription, patient or the caregiver, they're already upstanding, ready to walk out, and you know we're supposed to go through. Well, the doctors are supposed to go through each item and tell you what it
Yes.
is. That's how it is supposed to be.
Yes.
But sometimes
For
you're in a
your own good.
hurry to fill a prescription, but sometimes you want to because sometimes you say, you know, I have that prescription already and I have those medication. And I would say, or the doctor, some of the doctors, they will say, okay, don't bother fill that prescription. Fill it when the other medications are finished.
Are
Um,
finished.
are finished or finishing. For example, your diabetic medications, your blood thinners, your hypertensive medications. You're not going to wait until they're finished. Is when you're finishing them, that's when you do
Right.
the refill or you come back to
Yes.
the doctor for a rewritten prescription.
Yes.
Yeah.
Please do not wait until you're on your last tablet, like I
No,
do
no.
sometimes.
Right. So, yeah.
So wrapping
Don't
it up.
don't feel intimidated with doctors. I mean, I'm small in stature, so nobody usually feels intimidated by me. But we're willing to give the information. We're willing to, you know, get the
Yes.
older adults
Ask.
out. Ideally, in an emergency department, when a person, an older adult, especially if they're restless, we try to get them into a room. Well, if I'm on, and it's only because it's my specialty, I will say put this person in the room
A quiet
where they,
place.
yeah, a
Yes.
quiet
Away
place,
from the.
away from the high stress environment where there's less stimulation. Just put them in our room, and then the caregiver will stay with that person. But
Yes.
not every in an A&E, you may not have someone who is trained in gerontology and geriatrics and
Which is
understand
why
it.
we're
Right,
doing this so
right,
that you ladies can you can advocate and you can say,
right,
listen, you know, my mom, my dad is getting they're getting agitated, they're getting
right.
restless. Is there a quieter place that we can wait
You
or
can
so on
ask.
so that
Mhm.
you know and as I said, yeah, don't assume. I mean, you know, lots of things where doctors are thinking of a lot of things at once. I'm not trying to excuse them, but you know, if you have needs, advocate for those needs, you know,
Right.
which segues neatly into the little part of this conversation that's going to be about dementia and
Mm,
and any, you know, and the special considerations, one of which would be that, you know, trying to, you know, if in as far as you can, you know, they definitely need a calmer space, right, to be in. I think it's always good early to get out there, you know, not just dementias either, you know, children as well who are
yeah.
autistic or have, you know, people who are special needs in any way. You get it out there early with the doctor that this person has these special needs so that the doctor has an idea what it is that they're dealing with, right? So if they have, you know, if you tell a doctor, hey, they've got memory problems, that's automatically really helpful to the doctor because, you know, it helps them to understand that perhaps there's some questions they're not probably going to ask you instead of the
Mhm, mhm.
even though I would always advise that you make sure that the person is involved in the conversation so they don't feel like you're talking past them and all of
I
that
agree. I
also.
agree with that, Deborah. I
And
totally
that can be a real trigger too, and they're like, I'm right here.
Yes.
So
So
it's
we see this in the department quite often where you're like, so is this Miss So and so? So what tell me about her? You know, or I would say, um, so why are you here? To the patient. And it's like, no, man, she has dementia. She can't do anything. She can't do anything. And I
Yeah.
said, no, no, let her. And she would say, I don't even know why they bring me here. And I said, really? So what could, and we have a conversation and pretty much,
Patient, yes.
you
Yes.
know, and, but you always involve them. Never talk
Yes.
above them
Over them
or,
or yeah.
or talk as if they're not in the room. Sometimes I have to
Mhm.
catch myself and I say, look here, I'm talking about you as if you're not in the room.
You're not
You
here.
know?
I do it too.
Yeah,
I do
because
it too.
sometimes
Neither
you
you
think
can
to
vouch for
yourself,
me. I do it too. I'm
you
not. I'm
know?
not immune to doing that.
Yeah.
Having said that, everyone, every older person, talk about it a lot with dementia because with dementia, confusion is something that is fair every day. But delirium is something different, right?
Right.
And
Hmm.
it is really important that we really talk about, people who are suddenly much more confused than they were, I hear a lot like, it's just suddenly, suddenly they're doing this, suddenly they're doing that, or suddenly
Hmm.
they decide that this, or suddenly they want to walk on the street. Yeah, because they're more confused in an acute way, what we call an acute way, meaning that this is new. This is not something that is, they've always been this confused. If there's a sudden escalation in symptoms in a dementia, so if they're more confused than they were, we need to suspect that they might have something on board, an infection. They might be dehydrated. Tanya, you can a medication reaction.
Right.
Hey,
Right.
Tanya, you can jump in here, but be aware of the risk of delirium. And not only dementias get delirium, it's just harder to maybe see for the caregiver in
Hmm.
dementia because the person might have a certain amount of confusion on board already. But so the criterion for me is usually a sudden change.
Right.
They're increasingly confused. They have these brand new behaviors that you're like, what on earth is going on here suddenly? Like yesterday or 2 days ago they were fine, and now they're aggressive, or they're doing stuff that you've never seen before. But delirium can hit anybody. You hear? If you have a bad enough infection. Tanya,
It
I'll let
can.
you talk about that.
Right. So, as Debbie said, you have the delirium and dementia. It can be a little difficult with the persons living with dementia. So, I would ask any worsening of confusion. Say, oh, he's always confused. Yes, I know he's always confused, but compared to last week, how is the confusion? Is it worse? Is it boisterous? And remember, delirium, we tend to look at the aggressiveness or the aggressive part of it, but it can
Mhm.
also be hypoactive.
Yeah, they can get really quiet
You can get really
and
quiet
really,
or
yeah,
sleepy or lethargic.
yes,
So that
sleepy. Yeah.
can be delirium as well. So for the persons living with dementia, very quiet, not eating, so decreased responsiveness
Mhm.
as well,
That's a
or
great point
yeah,
because that
or
is true. Mhm.
or there's a heighten in their behavior, so they're more aggressive. And remember, anything can cause it.
Yeah.
Even if they're cold, even if they're too hot, even if they're dehydrated. And for older adults, they have lost the thirst response, so they will
Mhm.
not ask you for water or juice. So you and they
You have to be
you
making
have
sure that
to,
that hydration
yes,
is
you have to make sure that
continuous.
they're hydrated, and they
Mhm.
respond very acutely to any change in temperature, change in hydration, and so so that can cause delirium. Constipation as well can cause it. Ear
Go
infection, a
ahead.
lot of
Yes.
time they may have an ear infection. Impacted earwax, surprisingly, that can cause delirium
And
because
my
they're
favorite
confused.
all-time thing, a urinary tract infection.
Urinary tract infection. So,
Yeah, all-time common, really crazy journey
right.
kind of thing. For and
So,
and UTIs, we can do a whole separate caregivers
on urinary
spotlight
tract
on
infection.
UTIs.
Yes. And so once you come into the emergency department, I've told all the nurses, once they're 60 years and older, I don't care what they come in with. Do a simple dipstick, a simple urine test. Because sometimes I've seen where CT scan of the brain was done, CT scan of the chest was done, and the person had a urinary tract infection.
UTI, yeah,
I just
UTI.
so where's the dipstick? Leukocytes, pus cells, plus plus plus. Or they're dizzy, they're confused. Let me look in their ears. wax
Yeah.
compaction,
That
you
wax
know.
buildup is
And
crazy.
so
It's true.
there are many things that can cause them to present in terms of having delirium. And so we have to know that. And so when you come into the emergency room, you may come for one thing, but we're like, no, but this is happening. Why you have to do a urine
As
test? Why you have to
well.
do an
Yeah.
ECG? Especially if they also are diabetic, they may be having a silent heart attack. And so we have to assess them, because for diabetics, they may not have the classic symptoms of a heart attack. So we
I
test
didn't
them.
know
It
that.
can
That's
be very thorough with older
no,
adults.
well,
And so it
yes,
takes time.
you do
Yeah.
have to be. You do have to be very thorough with older adults.
Mm,
They're more vulnerable, and things that although I do want to say, as I said, for all of us who might be sitting here thinking we're exempt from delirium, you absolutely are not.
no.
So please, yes, and a lot of our research talks about the fact that the impact of delirium, sometimes some of that is permanent and some of that is long lasting, like 12 months to 18 months.
Right.
So
It can last.
delirium, yeah, so delirium is something that and you want to avoid it. I mean, if please do not delay if you have infections, etc. Get those things dealt with. And you definitely do not want to delay dealing with an older adult who is showing as is either escalated in behavior or completely de-escalated in behavior, who is
Yeah.
acting suddenly, as I said, completely differently than what they would normally do. And the generation that we are talking about who are older than us, they especially, they're very modest. They don't really want anybody looking at their urine. They don't want anybody, so it's highly likely that they're going to develop. We're a hot country, they're probably not as continent as we think they are, and they're wearing diapers and all that stuff. So and even if they're not wearing diapers, they might have like that dripping incontinence, so that they might have urine accumulating on their underwear. Sorry to be very graphic, but really important. I can't say enough about that.
Yeah.
In terms of really making sure, if you are taking care of an older adult, that you're checking on those things, because they really do impact. So running through really quickly for dementia, let the doctor know first that this is someone who has some memory problems or some cognitive impairment. The baseline stuff, normally they're like this, but today they're like that.
Mhm.
If they're having sudden things, sudden confusion, let the doctor know that that's quite different from another presentation, right? And just once the doctor knows certain things, that the person living with dementia is not going to do well with a 2-sentence instruction. You might want to take the time to give them simple instructions. So the doctor might say, I need you to do this for that and that, and you can take that and say to her, just turn over, right?
Mm.
So that if the doctor is not able to make it simpler, you as the caregiver who know that they need things to be simpler, just step in calmly and just say, can you just turn over for me, etc. Tanya has spoken about the quiet room, and obviously, if as much as we can in an emergency situation, how many people are running in and out of the room, right? And try not to let them do things like wander off, especially if they're confused. The last thing you need is for them to develop another injury, like a hip fracture.
Yeah, but sometimes if they're getting restless and they need to wander, you walk with them.
Go with them,
Go with
yes, so
them.
that they can let off some steam,
Right.
right?
Mhm.
And without stressing on the doctors. Restraints. You have anything to say about restraints, Tanya?
Um, I guess because studied in Malta, they're totally against restraint, whether
Yeah,
it's
I found
chemical
upon.
or physical. There are ways you can restrain them in a safe way. So make sure where they're seated, it's safe. And if they should get up, at least you may have a wall kind of stopping them. And it's good to just have the caregivers near them, because
Okay.
just restraint can hurt them. As physical restraint may cause bruising of the skin. Chemical restraints, of course, they come with side effects,
Yes.
and we don't want to zonk them out or cause
put them at higher risk of
force,
falls and
force,
other
force
injuries.
dependence, force
Mhm.
dependence, you know. So because when you give them chemical restraints, they can't talk, they can't move. You have to take them to the bathroom, and so you force them into a dependent state. So personally, no.
Yeah, I don't love them either. As I said, and we know
Yeah.
that most of them, even the nurses now will say, that is really frowned upon and should only be done
Mhm.
if it's, a very
But I find
extreme
once the caregiver is in the room, they're calm. Just hold their
usually.
hands. They're usually calm.
Because it work towards helping them to feel as safe
Mhm.
as
They
they
feel
can.
safer.
Right.
Yeah.
So we're kind of at the past time. I think we've covered everything that we kind of wanted to cover today. Let me
I
just
have
just
one comment, or just a
okay. So I was
reminder.
just about to say, do you have anything you want to add? Go
Right.
ahead.
So when we're dealing with, I mean, and I tell the, medical person and non-medical person, when dealing with persons living with dementia, live in their reality. So if they said, "Oh, where am I? I think I'm in Mobay," you are in Mobay, you know, because living in their reality helps us to be able to do what we want to do. If they
Yeah,
say, "I'm their granddaughter," I'm their granddaughter.
yeah.
You
Not the
know,
time for the arguing. No, man.
no,
Remember
no,
that.
no, no. I'm the doctor. Who's no? Mommy is the doctor. No, I'm the granddaughter. I'm trying
Yeah,
because I'm the granddaughter, and they may give me a name, and then yes, and so I'm able to be able to manage them properly. I get
yeah.
hugs and kisses when they're leaving because I'm granddaughter,
You're
or
the granddaughter. Yeah, and if
so
you
live
can work with
in their
that,
reality, live in their reality
yeah.
because that's the only way. I give an example. There's a lady who came from Mobay, was displaced because of Hurricane Melissa.
Listen.
Right. So she came down. She wanted, of course, because she's displaced, she started to show the signs of dementia.
Mm-hmm.
And so the granddaughter wasn't able to manage, but she came into the emergency. And I said, I have a friend. I soon come. And then I brought in the matron, and the matron said, her name, so for example, her name is Miss Mary. I said, "Miss Mary, what you doing here?" And she said, "Oh, you reached down here, so that is how we could get her to take our medication, eat." And she said, "Look, my friend come all the way
All
down
the way.
here, come look for me." And
Yes.
she ate. She met another girl in the emergency room, and and friendships were made. In her mind,
Mhm.
she knows them from. She just met them. Even the grandmother said, "So she know this lady?" I said, "No, but we just have to work, live in her
Yeah,
reality,
work with it,
so we
people.
can. Yeah, we have to work with it."
Work
So
with it.
everybody got goodbyes and kisses and hugs, and she took her medication and left.
Yeah,
So,
if they're happy, life is a lot easier with dementia if they're happy.
so
If
don't
we
fight
could
with them.
just
Don't
stop the
fight.
arguing.
Yeah, don't
Yeah, if
argue
we
with them.
stop
Don't
arguing,
fight. Yeah.
it's really not that big a thing. And when you get the cooperation and stuff, then you
Yeah.
realize that it's probably better. I agree with you. I always say like just into their reality and just let them be. If they're in Spanish on 1 minute and in Kingston in the next 2 minutes, just work with it. It's not really that serious as young people would say. So and it helps to get, especially in a situation like in, it helps to get what needs to happen done without a lot of struggling and arguing and all that stuff that's
Yes.
going to take up a lot of time and probably make an emergency situation worse than it is.
Yes.
I would say, I mean, as caregivers, as I said, you will know things about the person that the doctors do not know. So, as I keep coming back to what their triggers are, what is what they like, what they don't like, and so
Mhm.
on. So, make sure that you, as Tanya said, you stay close and you also let the doctor know. And you might have to sometimes communicate between make something simpler if the doctor in that situation cannot. And
Right.
now that we're wrapping up, because I think we have come to the end of this.
Yes.
Um, I intended for it to be an hour, but everybody knows me. My things never run exactly the time. It's how it is. I hope everybody got a lot of information from it. And now I want to ask if anybody has any questions. So if anyone has any questions, I'm just gonna jump right back into the community, Tanya, for a second. So if anybody has questions, just unmute your mic and have at it. I'm just gonna jump back to the community to see if anybody left any questions under the post that I put in the community today. So if anybody wants to go ahead, feel free. It's your time. Yep. And I just checked back, no questions. I bet you money that tomorrow or the next day we're gonna get like 16 questions, which is fine.
Yeah, that's fine. Yeah.
If there are any for you, I'll pass it on, and then
Yes,
we can
yes.
always answer them and stuff.
Just let me know.
Yeah, and the materials for this, the materials that go with this, the go bag and the checklists and the go bag and the scripts. I'm sorry. I'll put them in the community by tomorrow so that everybody can go to the classroom and download them if they want, and the fridge list, so that you can check your bag, and make sure that you have everything before you depart, to any. I'll try and have those things. Actually, I won't. Let me not say I'll have them in there by tomorrow, because what I'll do is I'll send them to Tanya first. So I'll probably post them maybe on the weekend. I'll just send them to Tanya so she can just run through and add anything if she wants to, in addition to what we have, so that you have a really complete handout. So I want to thank you guys for being here with us. The community is becoming more and more active. We're about to have memory cafes, and I wasn't able to do a memory cafe for January, but we'll have a memory cafe in February, and we'll talk about what memory cafes are. You'll have another, I may drag Tanya back to co-host. We'll have another talk at the end of February, which will be with Tanya, Patrice Dwyer, because I think we need to do a little bit of talking around final directives and people's final wishes and how to go about it. And Patrice has done quite a lot of work on that. And then again in March, we'll have another one of these with about recreational therapy and activities. So, there's a course on meaningful activities in the classroom, if you guys want to look at it. And as I said, the other thing that is going to come up aside from these lives, the 30-minute office hours I have every month. So you can always pop in and ask me questions. You can just look on the calendar and you can jump in and ask me anything that you want to. And then we're also going to have the memory cafe and some new coursing so that you can download the modules, the individual modules you might need for your caregivers, because not every caregiver is going to need the same thing. But some caregivers, it might be easier for you to just download that stuff and trade them. Tanya is going to have courses in the community, so I'm also introducing the people who I'm going to ask to contribute content as well. So because Tanya has, as a lecturer, she's got a fantastic set of stuff as well. So Tanya is gonna be someone who also puts courses into the community. As I said, like we're going forward in terms of trying to deliver more for our members as we begin to grow a bit more, and to have the community a bit more active. And of course, I can never say, with Grace sitting here, I cannot not mention our support group, which happens. It starts back the first Thursday in February, and it will be there the first Thursday in every month, for the rest of the year. Okay, I took January off because I was away actually, but from February back to the first Thursday, and anyone wants to pop up and talk about their care situation. We have veteran caregivers. I talk a lot generally, but the caregivers give a lot of great advice, and I'm really just here to kind of provide the space in which they can give it. So, like I said, stay tuned, guys. Hopefully, you'll get a lot more value out of the community than you've already gotten. And I hope everybody has gotten some value out of the community already. Tanya, thank you so much for being here with me. As I said, I may drag you back from time to time to kind of
No problem. No problem at all.
to
Thank
kind of
you,
co-host.
everyone. I have to run because I said I'm
Yes,
at work.
yes,
and
you
it's
do.
knocking on the door.
Tanya is at work. Thank you for giving us this time.
No
Everyone
problem.
else, thank you and
Bye,
good night.
bye.
Bye, guys.
Truly, bye. Bye bye.